Okay, well, if I'm not mistaken, we have our uh, four of our five panelists here, and we're glad that, first of all, everyone is here joining us on both Zoom as well as with Instagram. We're going Instagram Live as well. There are many questions, obviously, surrounding coronavirus and COVID-19, and glad we have such a distinguished guest of individuals with us. Just want to bring everybody into the room and, okay. Just want to bring everyone into the room, and in coming into the room, obviously they'll be, joining us in this session this evening. In addition to our panelists, we do see some distinguished individuals here. We have State Representative Roger Bruce here for the state of Georgia, who joined us, and you're probably going to see quite a bit of Morehouse in the building. Obviously, somebody's a Morehouse grad right here, right? But we're not bragging. We're not bragging. So again, we're glad to see Representative Bruce. We also have United States Commissioner William Clyburn, who's with us as well, and Councilwoman Beverly Clyburn, who's here. So again, I could go on and on with the individuals who are in the room with us, but we really need to get into the conversation. We have our guests here, and I'll just briefly mention their name. And once we mention their name, we'll allow them a few minutes to say some words about their work given this time in America, which has been like no other. Obviously, we're dealing with coronavirus and COVID-19. We've seen many reports, obviously, over the past few weeks as to the devastation that's going on. And we have these experts here that's really going to talk about that experience. So again, glad that everyone is here. We're going to go ahead and sort of go around. I will just briefly mention the person's name, and then they will give an introduction, and then you'll open it up within about the next 15 minutes or so. So with that, I want to start with Dr. Jasmine Ward, and again, Dr. Ward has been very integral. Some projects that we've worked on together, and again, I want to thank Dr. Ward for taking out time of her schedule to be here. Fortunately, we do have representatives in our panelists that are in different geographical areas, different geographical regions. Dr. Ward, please, can you tell us what's going on there with coronavirus, the type of responses used, and also the responses that's going on with the government? So please, Dr. Jasmine Ward.
Okay, I'm sorry, Ted, I couldn't unmute myself. Hi, I'm Jasmine Ward. I'm here in Arlington, Texas. I thank you first, Mike, for bringing us all together for this major initiative. I think it's going to be a lot more than this one call for sure, to really start to think about how we are not only maneuvering through this time of our lives, but also recovering in the future, how we recover from this, and a lot of things that we are learning from this experience. So I am the founder of Black Ladies in Public Health. We are a group of women who represent the diversity of public health in its entirety. So we have women who are students, women who are professionals within this field, researchers, practitioners, and also those who we consider to be our friends within this space. So non-traditional partners who may not have a public health degree, but certainly doing public health work. And we have seen through this crisis how much public health extends itself out to various fields. And so we have been working together to really identify spaces in which we can assist and build capacity for organizations and local municipalities as it relates to best practices in this time. We know that there are various issues that we have found within our workforce and our infrastructure, and certainly our communities, that we want to address as Black women in this space. And so we are working hour to hour. We actually have a call tonight. We bumped the call a little bit to make sure that we could, participate in this call for sure. But we're working and trying to really help to build capacity of those institutions that I mentioned, but also consider the health and well-being of those of us within the public health workforce, and also our families and friends. So we are trying to stay updated on things that are, unfolding. And we're really, this has been one of the, I think this is the task that we all have been called to in public health, to really step up and show what we have been prepared to do. And so we have been trying to reassure our families that we certainly know that it's a difficult time, but, practicing social distancing and things like that is important. We are trying to follow interventions and mitigation strategies as they come, develop in different cities. So it's a lot when we consider just the diaspora of Black women, that we are representing, and also the age range and the expertise that we have. So hopefully we can add to this conversation. There's a lot of women who should be attending this call for sure.
Okay, Jasmine, thank you very much for your comments there. Again, she's with Black Ladies in Public Health, and again, she'll make sure that, and Jasmine, if you don't mind putting your website into the chat area so everybody can have access to you, please, if you don't mind. Let's continue with our panelists here. I have Erica Satin Hernandez Wells, who is a student of mine at Simmons University. She's in the MPH program. That's where I teach. Simmons, of course, is in Boston. And Erica, we've had a great term. We just wrapped up our term. And I have many students, and Erica, with the work that she's doing, I said, well, could you please share with our group this evening? Again, she's doing some very serious work with community there in Boston, and I'm just proud of the work that she's doing. So I'm not going to belabor. I want Erica to really tell us about what she's doing there and how it benefits local communities. So Erica, please.
Thank you. Hi, my name is Erica Satin Hernandez. I'm a student of Professor Weaver's, and in my day job, I'm the coordinator of Shape Up Somerville, which is an office in the city of Somerville, Massachusetts, Health and Human Services Department. And in more standard times or more typical times, we'd be working on food system planning, as well as promotion of safe, active transit and other physical activity opportunities. And so in this moment, we're trying to coordinate the different actors in the food system in Somerville to see how we can ensure that everyone continues to have access to the basic needs that they require. And so there's a lot going on across the city. We're a very small city, so it's 4 square miles, but it's also the densest city in New England with 80,000 residents. And so the couple of things that I'll just mention in the food system world are that we've been talking with the food pantries across the city, hearing that between the COVID pandemic, as well as the changes to the public charge rule that have just gone through, and immigration issues are very, very salient in our community, that the food pantries have been just completely slammed. So we wrote a quick ops guide, and we've opened up a supplementary pantry to try and take some of the heat off. We're primarily doing deliveries to homes to make sure that everyone has food that they need, obviously for free, getting our resources from the food bank, working with local organizations who do rescue and redistribution. Last week, we distributed almost 300 bags to almost 100 households, and we're on track to exceed that number this week as the demand is just continuing to increase. And I'll also mention that the public schools are continuing to produce breakfasts and lunches as they normally would. And so we don't have school buses in our district because we're quite small geographically. So other districts we've heard of are sending food on the routes that school buses normally take and dropping off at each location where they'd usually pick up a child. And so for us, we've opened up 4 of our 7 schools for meal distribution, not just for the children, but also for any member of the family. So trying to make sure that all the school families not only have their meals, but they're also doing distribution of distance learning tools that may be necessary. And they're up to about 1,000 meals per day at the schools. So the need is continuing to grow, and as we're trying to create these additional emergency resources, keeping an eye to the systems that are in place and seeing what else needs to be built in on a larger level to ensure prolonged access to food, given that this is going to continue on for quite some time and really change the way that we typically operate. So that'll just be the quick 1-2 on what we're up to in Massachusetts.
Yeah, thank you, Erica. And we will, explore that some more as we go through this evening as well. So thank you for that overview for what you're doing there in Somerville. Great work, great work. We're going to go to Dr. Joe Salisbury. Dr. Salisbury and I went to Morehouse, this little school behind me here. Dr. Salisbury has always been community conscious. We're very appreciative of his work that he does professionally, as a family physician, and then also what he does by giving back to local community. So when I put out the call, Dr. Salisbury was one of the first people to come through, because again, the call just went out yesterday, and here we are 24 hours later, and we're here. So that notwithstanding, again, Dr. Salisbury also went to Morehouse School of Medicine, for his medical degree. I'm not sure where he did his training, but again, I'm sure he can share that with you briefly. So Dr. Salisbury, please, can you give us sort of what goes on in your family practice there at Wellstar on a daily basis, given your coronavirus and COVID-19, please?
Thank you, Michael. Welcome all of the panelists and guests. Joseph Salisbury, the second MD, board certified family physician here in the Atlanta area. I'm also a diplomat of the American Board of Family Medicine. I currently work with Wellstar Hospital System. I am the lead physician for the urgent care unit at both Stockbridge and Camp Creek here in the metro Atlanta area. As Dr. Weaver said earlier, proud graduate of Morehouse College, Morehouse School of Medicine. I did my family medicine training, University of Tennessee, Erlanger, Chattanooga, Tennessee, where I finished my residency as the chief residency. I've been with Wellstar now for a while. Obviously, I'm on the front line doing urgent care. We've been following this pandemic for the past 30 days. And, we're on the front line. I've actually already seen and tested several individuals who have come back positive for COVID-19. I'll share with you briefly a gentleman I saw just last Wednesday in my office. We looked at him, we ruled him out. He came with a fever. We ruled out flu. We got a chest x-ray, and he showed bilateral pneumonia, which is now sort of a telltale sign of COVID-19 as we go about this. This is something we're learning as we speak. The numbers are changing. I mean, I think before I came on, I think the number of cases in the United States right now are approaching 160,000. I think the number of deaths are right at 2,900. Just here in Atlanta alone, in the state of Georgia, we've had over 2,800 cases. And then we had 700 people test positive. So, the numbers are starting to really, the curve is starting to escalate. And so, we really have to try to get ahead of this. But once the horse is out of the barn, it's sort of hard to catch that horse.
Okay. Yeah, that's quite a bit. And I'd imagine your stress level around this time is probably more than what it's been in the past, I would imagine. Because again, you also have to really be concerned about your own health at this point. Any type of precaution that you take when you actually go and see someone, again, displaying this bilateral pneumonia?
This gentleman presented, healthy 51-year-old black male, had a fever for several days. He said he'd been fatigued. He was having issues climbing his steps at his house. One of the health issues he had was hypertension, which was controlled with medication. Again, we have a protocol that we put in place that anybody who comes in who's febrile, we have an actual screening questionnaire where we ask them if they've been in contact with someone with COVID-19. We also ask if they've been in any endemic areas in the world and country now with COVID-19. Also other questions like shortness of breath, if they're over the age of 65 or 60, if they have any type of comorbidities or immunocompromised type of medical issues, then we screen those people and then we put them in certain rooms and we gather our PPE, our personal protective equipment, and we go to work.
Okay. All right, well, and we'll have Dr. Tracy Nelson to sort of pick up from there. Dr. Nelson is an MD. She's an OBGYN, and she went undergrad at Dartmouth and medical school at Yale and did her OBGYN residency at Penn. So she's triple Ivy League. And we're glad and grateful that Tracy's taking time out of her busy schedule as she has her own practice with some partners, and but she's there in the Myrtle Beach area. So Dr. Nelson, again, can you sort of give us your experience as OBGYN and to some degree sort of build on what Dr. Salisbury just mentioned? Wait, let me unmute you. I think you're... You have to unmute yourself. Okay, you're good now. Okay.
No, thank you. Thank you for inviting me, and thank you for initiating this format. Just as an aside, this format, I just became familiar with Zoom, and an unexpected consequence or unexpected benefit of using of the coronavirus crisis is the use of telemedicine, which Dr. Salisbury probably can implement in his practice, and it's something that we'll be implementing in our practice because I am an OBGYN, and half of the practice is GYN and half the practice is obstetrics. Understandably, all of the pregnant women or those trying to become pregnant are concerned. So to protect our pregnant patients, we are trying to implement some visits via telemedicine, and this is a great format. For the other pregnant women who have to come into the office, again, we're using a screening technique at the front door, checking to see if they have a fever, which is defined as 100.4 degrees, whether or not they've come into contact with somebody, whether or not they've had a cough, and if they've passed all of those parameters, we take their temperature and then bring them back. Patients are waiting in the cars. Again, another little convenience of having cell phones. They wait in their cars. We call them in and take them directly to their rooms, so there's no congregation in a waiting room. And those are some of the kind of changes I've made in my day-to-day practice. As far as the virus itself, there's limited experience in obstetrical patients. Most of the information we have is coming from the Chinese, from the place where the epidemic started. And I'm being cautiously optimistic. So far, having had COVID does not make you any more susceptible other than a general population. Normally in pregnancy, because of some physiologic changes in the lungs and because of suppression to the immune system to continue with the pregnancy, pregnant women tend to get a lot sicker. For instance, influenza is way more dangerous in a pregnant woman than a non-pregnant woman. Thus far, we are not quite seeing that. So a pregnant patient has the same risk as a non-pregnant patient. The other information that's come out of China is, like I said, again, being cautiously optimistic, is so far no virus has been noted in breast milk, vaginal secretions, placenta, amniotic fluid. So any babies that, out of 38 patients, 3 or 4 babies became COVID, were positive. It was determined that those babies were infected postnatally by having contact with their mother. So for a pregnant woman who is COVID positive, the recommendations are to deliver the baby, clamp the cord immediately, no delayed clamping, and whisk the baby away. Now, some of the experience that I've had with my colleagues at MUSC with the high risk obstetrics, apparently because of some of the diminishment in the lung capacity and because pneumonia is the consequence of the COVID, that's what kills people. Some of these women cannot labor. So the babies come in, the moms look okay initially, but they can't tolerate labor. There's just not enough oxygen that's getting to the babies, and those patients are being sectioned. In China, most of those deliveries were via C-section. So obviously it wasn't really delineated, but those babies did not tolerate labor as well. Hello?
Yeah.
Okay, it was.
Here, Tracy.
So the other issue with regarding the virus, because I'm sure all of you remember the Zika virus, which caused developmental abnormalities, mostly microcephaly, small heads. I am waiting to see is what exposure during the first trimester, if it will have any adverse impact on the pregnancies. Because the epidemic or pandemic started in December, most of those women, and again, it's mostly from the Chinese data, most of those women were at least in their third trimester, and apparently there's no sequelae, there's no adverse effect on those pregnancies due to the virus directly. What I'm waiting to see, and hopefully it will be okay, what happens if there's first trimester exposure. So the first trimester exposure data should be coming out in April, about May or April, because if those women were pregnant in December, we should start seeing if there's going to be any ultrasound abnormalities, any stillbirths, anything like that. We should start seeing that data come out, like I said, in April, May. So hopefully there will be no problems.
Okay, Dr. Nelson, well, thank you again. That's a concern for all of the mothers, want to be mothers, soon to be mothers, whatever the case may be, but it's also a concern for the larger society because these are the women that we're talking about that are in our lives. And again, we're glad, Dr. Nelson, that you're very well versed. And any patient of yours, just blessed to have you as their physician. So we thank you for that that nice take on what's going on with pregnancy and women. With that, we actually had another physician, Dr. EmPower Brown, who's in emergency medicine at Stanford University. Oh, Dr. Brown is here. And he's ready. Okay, I didn't make it. Okay, well, great. Well, so Dr. EmPower Brown is here. I guess we've all changed the look up a little bit. Dr. Brown, he's here, and we're thankful that he's here. He is one of my students. Again, I told you Morehouse is going to be mentioned quite a bit. Dr. Brown was in my intro to epidemiology course at Morehouse years ago. And we're glad that he was able to go on to Boston University to get his master's in public health, and then with the Meharry to get his medical degree. And now he's there at Stanford. And so, Dr. Brown, again, we know you're on the front line as well as the other physicians, as well as Erica who works, and Jasmine. And can you just tell us what's going on there in Palo Alto and with coronavirus and exactly the work that you're doing, please?
Dr. Weaver, I appreciate you having me. I want to make sure my sound level is good. I live in a community that has a bunch of different cultures and a bunch of young kids. So if you hear sounds, that's because they are trying to use this daylight to their best advantage and try to get as much as they can before we have to be back in our shelter in place orders. So with that said, again, thank you for having me. COVID-19 is the biggest public health crisis that I think millennials have ever seen, and maybe even some earlier generations. And as a person who is kind of like in that age range and operating on the front lines in emergency medicine, we're seeing something that we usually don't see, which is younger patients come in and have respiratory failure a lot earlier. And without any other comorbidities. So that's kind of like the first major message that I'm bringing to the group is, we were told initially from studies in China and from Italy to expect older patients with multiple comorbidities to be the predominant amount of cases. And what we're seeing is a surge in people who are younger, so sub 50, even as young as 24, 25, getting intubated within, 20 to 30 minutes of them arriving. This is a lot different than the picture that's painted from us, from our overseas colleagues. The other thing that I would like to share that's a lot different is on the front line, like the way that resources are allocated per hospital is completely, it's something that, if you're in a county system, you may have more access to, you may not have as much access to PPE as in a private system or an academic institution. But now you're even seeing academic institutions struggle with trying to procure proper PPE. So this is a nationwide trend. You've paid attention to some of the updates. So outside of just the clinical manifestation of COVID-19, there's a secondary degree of burden that providers are encountering who particularly are working at the front lines. There's another thing that I think I would mention as like kind of anecdotal evidence is the misinformation around the way treatments work is essentially putting people at higher risk. So I've had several COVID positive patients. Like I test somewhere between 20 and 40 people a day when I go to work. And of that, I might get 8 possible positive tests. But you'll have individuals come back and request the medications that were stated in the presidential address. And the fact of the matter is that while there are trials going on about with chloroquine or hydroxychloroquine, as well as azithromycin, the N, or the number of cases that we're judging this efficacy on, is extremely low. And so it's kind of hard, and it's too early to say now if this is a treatment regimen or a protocol treatment regimen that we can implement widely. So that has become a tertiary burden, which is individuals re-exposing into people who are in the hospital just for coming and inquiring about medication. So a lot of this has been, the burden has been placed on telemedicine, telehealth, to be essentially the stopgap in trying to keep individuals from coming to the emergency department who can get questions answered without presenting. And for ER physicians, what we've been trying to do is still keep up with the respiratory complaints. I mean, for example, in my hospital, we have split our ED into certain wings. So we have an entire respiratory wing. And so I, as a lower risk physician, tend to work higher risk shifts to protect my older colleagues. So I will go in and do the drive-through screening. I will go and do the complete respiratory wings. I'll manage a critical care wing. And then my higher risk colleagues, meaning people who have like history of a kidney transplant or have multiple medical conditions, will work lower risk shifts, like the telemedicine shifts, or possibly even like an observation unit for non-respiratory complaints. So, I mean, there's a lot of operations things that are occurring to try to optimize available resources. But I guess my main message to the group is from the front lines, like there is a different picture being painted. And that picture is, I think that we do not see an active flattening effect fully. We are in hot spots across the US. Like I trained in the Bronx, and my colleagues in the Bronx are intubating 6 or 7 patients a day, seeing 20 deaths on the weekend. You know, this is not normal. It's not normal at all. And I say that because like that, the imagery is that, okay, we're doing the right things and we're getting the desired effect, when really we haven't seen the full span of its secondary implications, like the patients who are the walking well, who potentially will come back in 5 or 6 days after they really do become short of breath or really do demonstrate the symptoms. So you think that they're fine when they test positive, and then they return to the emergency department and they're being intubated within like an hour, because we have limited range of things that we can do without trying to aerosolize their droplets. So, I mean, I know that's a whole lot to unpack, but I wanted to give you at least enough meat of what I experienced so that you had something to work with.
And Dr. Brown, we do appreciate that. That is exactly what this forum is for. We do want to hear those real stories. I mean, the ones that each of you have shared, you're being right there on the front line, dealing with patients, dealing with the public. That is what we all need to hear, because I mean, there are those who say that the numbers are underreported, right?
It's a fact. It's a fact. I mean, not only is there underreporting because the testing itself is not uniformly available. That's the first thing. If you're in a community clinic, it's likely that you have a limited number of tests. If you're in a federally qualified healthcare center, unless you have a partnership to where you can get access to more kits or testing kits, it's a little bit harder to come by. And then there's the fact that protocols differ from institution to institution. In fact, they change daily. There was one point where we weren't testing individuals who didn't have, like you had to have a known contact for us to even offer you the test. And then it turned into, all right, anyone with symptoms plus known contact. And then it became, there's asymptomatic cases. So it's if you just request a test. And now the tests have become so, the laboratories have been so inundated with testing that you have to use a little bit more clinical gestalt to determine who actually can get a test. So it's just inconsistent across the board, and you really have to look at the case individually and see, like, what is the yield of me doing this test? Could I just tell you to stay home for 14 days and presume that you are positive and save a test for somebody who's really on the verge of, like, for example, a cancer patient who needs to be admitted for neutropenic fever, and you need to know, do they have COVID or is it just another source? You know what I mean?
Right.
So.
Yeah, well, you know, and again, we appreciate that. I mean, those are real live stories, and you know, those are hard decisions that have to be made. Again, when the tests are limited, and that's what we're hearing. You know, Dr. Salisbury mentioned it. You know, that again, when the tests are limited, then it is a matter of who can we administer those tests to, right?
Is it okay if I say one more thing?
Yes,
just to be okay? And then the last part, and this is more so from my colleagues who are in New York. I mean, no provider leads in with wanting to make the decision about who deserves to get a ventilator and who doesn't. This is a very difficult conversation to have, and most providers are not trained to lead into that discussion. Most of the time, this discussion goes to a higher board, like a review board or an institutional board, who will discern which patients would fare better on a ventilator and which wouldn't. And in places like New York, particularly communities of color in New York who are seeing increased amounts of people come in with respiratory failure and having to intubate them within moments of them arriving, they are being pushed to the edge to where those decisions are being made. And that's the scary part, is that you've got multiple metropolises who are at this brink. That's Detroit, New Orleans. You're seeing a rise in Atlanta, but particularly pay attention to New Orleans. They do not have the infrastructure to get that many ventilators, and they have tons of comorbidities. So the lesson from New York should be that providers are essentially being forced to, like, figure out how to solve a problem when you've got 20 patients in need of a ventilator and the whole hospital only has 15.
Okay. Well, on that note, let's because we want to be true to the audience here.
Sure.
Yeah. Thank you so much, Dr. Brown. Yeah, we want to be true to our audience and allow them to have questions, because that's what we want this interactive dialogue to be about. Again, we've gotten quite a bit of information from each one of the panelists here, and we do want to allow the opportunity, as we mentioned, in whether you receive this through text or through email or whatever the case may be. We want to hear from you. For those of you who have joined us, we're sure that you have questions. We want you to hold your questions to your question, singular question. Again, we have our panelists here. Again, we have Erica Satin Hernandez, who's there in the Boston area. And again, she's dealing with the feeding program with the school system. Again, we have Dr. Jasmine Ward, who's there in Arlington, Texas, with Black Ladies in Public Health. And again, you know, just working within that space and making sure that, you know, women are well, Black women are well. And so if you have any questions for her, obviously we have, you know, Dr. Tracy Nelson, OBGYN, Dr. Joseph Salisbury II, who's with us as well. He's family medicine. Of course, you heard from Dr. Brown. So if you're with us, again, we want to honor, and I do see some guests. Again, you know, Representative Roger Bruce is here. Representative Eric Allen is with us as well. Another Morehouse man, another member of Kappa Alpha Psi, Dr. Harold Moore Jr. Is with us as well. So we thank Dr. Moore for being with us. But with that, though, I do want to open it up. If you have a question, please raise a finger and I will unmute you, right? So that means you have to have on your video for me to see you. And then you raise your hand and you can ask your question. So is there anyone with any burning question? Again, we have these distinguished panelists here. Okay, we see Tanya Jordan. Yes, go right ahead, Ms. Jordan.
Hi, my question is for Dr. Brown. Dr. Brown, do you feel like the numbers are being underreported in the media?
Did you,
Can you hear?
Cool. All right. Yeah. So I think the numbers are, I mean, they're definitely estimates. And part of it is due to the process of reporting. Like, some are reporting to their county health department, some are reporting institutionally, and the institution is batching the data and then sending it in numbers. So that's like a part of why you're getting a staggered number. I typically go to Johns Hopkins website. They have a coronavirus center that has a virtual map, and it shows an update probably every 6 hours of what the active cases are, as well as cases that have been resolved or recovered. The other thing that I would say is I believe that there's active suppression of data, particularly around race and ethnicity. If you've ever watched any of the reports, they do not thin slice it. They pretty much tell you what aggregate data is. They'll also give you a couple of details around age breakdown by rate, like mortality rate. In the medical community, we're operating essentially around a lot of the normal reporting agencies. If you're on a physician's thread of this, like a COVID thread on Facebook, we are having in like real-time discussions with data sharing that is bypassing journals, that's bypassing media sources. And so I'm telling you, I'm getting the data from talking to Italian physicians and physicians all across the US. So my response to your question is the data is accurate with an asterisk.
All right, thank you so much for that response. Did I see any other hands? Okay, Ms. Robinson, let me unmute you and then we'll come to Representative Bruce afterwards. So Ms. Robinson, please ask your question.
My question as the founder of the Black Heart Association is, how is this looking as far as, the underlying condition being cardiovascular?
Okay. One more time, Ms. Robinson, if you could repeat that.
How is this looking as far as COVID with cardiovascular disease being a very serious concern for us that have those underlying conditions? What's happening when when people arrive just with that issue alone? What are they being told?
Okay. Anyone want to take that?
I'll take that, Dr. Weaver. In regards to your question, Ms. Robinson, cardiovascular disease, obviously you're talking about hypertension, congestive heart failure. You're talking about clogging of the arteries of the lung, people who've had bypass surgeries, things on those lines. They are a risk. You are a risk. But you're not stratified like some of the other comorbidities. For instance, people with asthma, people who have COPD, obviously the elderly, again, people over 60, 65, people who have diabetes, people who have rheumatoid arthritis. There are a number of autoimmune disorders, lupus, sarcoidosis. Those are all issues that honestly impact your respiratory system in such a negative way that when we see those patients, they are of heightened concern and risk. So cardiovascular stratification right now, I wouldn't say it is high as those, but it is on the list.
Thank you, thank you. Dr. Nelson, do you want to add anything to that?
I couldn't hear you. Say that again.
I was just wondering if you wanted to add anything to Dr. Salisbury's statement or.
Oh, I mean, we all know those comorbidities. Again, of course, in pregnancy, there's always the hypertensive disease, the spectrum of preeclampsia, and that would also make you a little bit more susceptible to some of the complications of the COVID virus. So even if you were not hypertensive before, but you develop it as a complication of the pregnancy, anything along the hypertensive spectrum, which is preeclampsia, HELLP syndrome, you're going to be at larger risk or bigger risk for developing the complications from the COVID virus, just like a non-pregnant.
All right, great. Dr. Brown, I see you had your hand up, and then we're going to go to Representative Bruce for his question. Yeah.
My only comment is, for those who have cardiovascular risk factors, understand that this changes the scope of available services to you. You can't necessarily get elective procedures done now because some of these, the OR suites are being told not to do some procedures because of risks. And then also, if you come in with some type of weird arrhythmia or whatnot, they may not be able to do a cardioversion, or these procedures have been essentially like, they're being very judicious about how they manage patients because of the risk of just coming to the hospital. So that's what I've added.
Okay. Yes, Dr. Nelson.
I'm just so interested in hearing what Dr. Brown has to say, because I'm in South Carolina, I'm in Myrtle Beach, obviously, and my hospital, we've tested probably a limited number of people, have only had 6 positive, only 1 death. So from my perspective, it looks like we're starting to flatten the curve. However, all of the New Yorkers are now coming to South Carolina. So we're getting prepared for maybe this onslaught of COVID, either infected or suspicious persons. So, you know, I personally feel a little bit of a lull. And to hear Dr. Brown really experience what I've seen on TV is the jolt I needed to just stay as diligent about practicing protective measures, washing my hands, and making sure that I pass that along to my patients and my colleagues, because we're getting a little bit low that this might be okay.
And it's definitely not okay. Let me go to Representative Bruce, please.
Hi, everybody, and thank you for letting me listen in. This has been good for me because we get a lot of people asking us questions, and we're not medical professionals, and we get so many different mixed messages. But a question that keeps coming up is whether or not this virus can be transferred by mosquitoes. Mosquito biting somebody and then go and bite somebody else. There's somebody infected and biting somebody else.
Okay. Thank you for that question. Who would like to answer that question? Just jump right in. You're not muted, so anyone who'd like to answer, feel free to.
Yeah, Representative Bruce, I have not heard of any of that transmission at this point. Obviously, Dr. Nelson brought up the issue earlier. It happened in Miami years ago. It led to microcephaly and things along those lines. But you know, this is a very fluid situation, and so things are changing even as we speak. You know, tomorrow, I can't tell you the countless of emails that I've gotten from my hospital system in the last 3 weeks regarding this. So that question, Representative Bruce, may very well be answered once the OBGYN community gets those studies that Dr. Nelson talked about by the end of April, 1st of May. But as of today, I have not seen anything, and I would defer to my colleagues on the panel if they've heard anything different.
I have not.
Okay.
We the only information that I've read is that as the weather gets warmer, that it'll sort of follow the same course as the influenza, and as the weather gets warmer, this may peter out. But that's, as far as mosquitoes, I haven't heard anything that say yay or nay.
Yeah, no. So, I mean, it's a lot of confusion, I think, that goes around when you're talking about transmission, right? So this is not airborne. That's the first thing that people need to understand. Like, it is not something that just by walking in the environment you can catch. It has to be passed via respiratory droplet. So that means a droplet lands in a mucosal surface and then is absorbed, right? So it's a little more difficult to think about whether mosquitoes would be able to have that impact. It's not something that's common. I mean, Zika is a different organism altogether. Like, this is not the same pathogen, right? Mm-hmm. The other thing that I would say is while we do understand that in most situations flu dies off, it's kind of like, I think the word is biurnal. I don't know what the word is exactly, but it has a modality, right? Like a bimodal presentation. The problem with that is other epidemics that we've seen, like SARS, for example, had its onslaught in colder months, but I want to say West Nile started in the summer, right? So we don't have any clear indication that this is going to die down just because the weather changes. And that's something that's been proposed a couple times. In fact, if you listen to 45 give his talks, he almost alludes to it like, oh, we're going to see the numbers change when it gets warmer. But science does not necessarily indicate that that's what's going to happen, because we've had worse epidemics that occurred when it was warmer months out. So I guess my answer to you, Representative Bruce, is that as Dr. Salisbury said, the data isn't there yet. It's not even something that we're even in a place to test, really. More importantly is that we do know how it is transferred now, and ways to start to affect that transmission now is what people need to be paying attention to at the highest extent.
Real quick, Dr. Weaver, I just want to piggyback on Dr. Brown real quick. Now, there are studies right now that are coming out of China as well as Italy that there is an oral fecal mode of transmission as well. So we need to be very clear that now we have to expand the fact that oral fecal transmission is another route in which people are actually starting to get COVID-19. That has just come out. It's just been published in the past week, and it's starting to actually gain a lot of momentum. So again, Dr. Nelson mentioned something very, very basic. Have our patients, have our communities and friends wash your hands with soap. The reason why we're advocating people to wash your hands with soap, because all of our medical personnel on this panel know that a simple virus, its cell is broken down by the emulsification of fats, okay, in the soap. So it actually breaks down the barrier of COVID-19 and actually kills it that way. So the importance of washing your hands when you go into the restroom is very, very important as well.
And thank you for that. And again, I'm watching the clock here. We said we're going to be prompt, and we started at 7. We want to make sure that we end at 8, but we want to try to make sure we get some get as many questions in as possible. Vicki Leverett, she is not able to be on video, but she does want to make a comment. So, Vicki, we can hear you, even though we may not be able to see you. So please go right ahead.
Okay, thank you. I just wanted to share with the group my friend's experience. She was just released from Einstein Hospital in the Bronx. Oh, that's your hospital, Dr. Brown? Well, she said she was admitted last Tuesday night. She'd been sick for a little over a week. She said like cold and flu complications. She's a very healthy person. And I think around last Tuesday, she said she went to work and she got to the point where she couldn't breathe. So her husband took her to one of those Medi centers. From there, they told her she had to go to the hospital because she just couldn't breathe. So this was Tuesday night. She did not get the results back until Thursday morning. And right away, they started giving her, and I know I'm going to say this wrong, the hydroquinone, however you pronounce it, it's the malaria drug. They gave her that and the azithromycin. She was released yesterday from the hospital. She had 5 treatments. But with that, it worked out well for her. But her first cousin, who, if you live in the New York City area, you saw in the Daily News, the second victim of the COVID virus, who worked for the NYPD, she had been diagnosed and they sent her home. And she pretty much just died in her doorway. She was home with the COVID virus, and when she finally decided to call 911, it was too late. So I just wanted to share that kind of out. I'm a lay person, of course, but I just want to share what my personal experience with, I live in New Jersey. So it's kind of scary for us over here too, because we're just like 30, 20 minutes right out of New York City. Just wanted to share that.
Okay. And Vicki, thank you so much for sharing that. And I'll be the first to tell anyone, it is because of Vicki that we're here. Some of you know that I'm a workout buff, in addition to being a distinguished college professor. But Vicki, when I was doing a Facebook Live during one of my workouts, she just asked a question about COVID-19 coronavirus, given what she just mentioned. And I really, at that point in addressing it, said, well, let me just bring some of the professional people that I know, some of the people who are doing work front line to the fore, you know, and to put them in the public space, which is what we're doing right now. And so again, Vicki, you know, really just put that on me on Saturday, and here we are about 48 hours in a session. So again, I want to thank Vicki for bringing that, for asking that question, and again, having me to go through my network of people, and again, for all these distinguished panelists to be with us tonight and to present. So now, Dr. Ward wanted to mention what's going on with health literacy as pertains to coronavirus. So Dr. Ward, please.
Okay, I gotta wait on you to unmute me. So I do want to address the questions about reporting. So we have seen Black Ladies in Public Health. We've been trying to follow the reports statewide, state to state. Of course, we're following using the Johns Hopkins app, and we have found in the visualization of the spread. And I do want to mention Virginia has reported out disaggregated, a little bit more disaggregated data. So they do have gender and race. And that has prompted some conversations around testing for communities of color in particular. And then also Milwaukee had what they've dubbed a crisis within a crisis, where you have a cluster of Black residents of their north side who have not just higher rates, but also deaths. So I think it was something like 8 out of 14 deaths as of last Saturday were Black individuals. So that has prompted some conversation, certainly, but there are lots of places that I think those are the only 2 we were able to find that really had some information provided as to and testing, but that's really not even addressing a lot of the other things that we want to see happen as it relates to equity and things that we know that we've lacked in prior to COVID-19. We are now seeing those things exacerbated in this process. But I do want to mention when we're talking about individuals understanding the messaging that we're providing, we are looking to do what we can to really support understanding from our communities about the importance of these mitigation strategies. So when we're talking about social distancing, or what we're now saying physical distancing, those are important strategies, but also thinking about contaminated surfaces. So for a long time, things are changing so quickly, our messaging is changing to keep up. But those can be literally in days. We go from 250 people in a room to 40 people to 10 people within 2 days. That's the messaging has to get to the critical masses. So we do need to start using some innovative strategies to get that information out to people and to large groups of people who really do need to understand the importance of it. Even simple things like, what is your home hygiene? So when you come home, if you are an essential worker at a grocery store, you may not have the medical understanding of how this virus is transmitted and what it means to come into your own home, and not just your own home, but even going to work. So we're trying to figure out how to even communicate messaging specific to those individuals, because when they're coming home, they don't want to bring the virus home, right? They want to be protected in their work. And so those are things that we have to think about, especially when we're talking about communities who are oftentimes, in positions where they can't work from home. And that is obviously from a privileged perspective when we say stay at home, but some people cannot stay at home. Obviously, the medical workers know. We have mothers, single mothers who are raising children, and they are talking about the dilemmas that they are having with going to work, not being provided proper PPEs, and also thinking about the conversations they have to have with their children in the event that they do get coronavirus. So these are tough conversations, and we're having them all over the place. But in terms of understanding how to prepare for this as we move forward, we need to keep the conversations going, but we also need to come up with some real strategies and assistance for people who may not have the agency to really chart different territorial paths. When we're giving them one recommendation, they really can't do that.
And thank you, Dr. Ward. Erica, can you add to that again, given the setting that you're in there, seems like what Dr. Ward just mentioned is sort of hand in glove with what you're dealing with there in the Somerville area?
Thanks. I'm furiously taking notes because this is such great information. And so my corner of things in Somerville has been primarily on getting food to people that aren't able to access it. We're hearing a lot, as Dr. Ward was saying, of people that are still working and not able to access some of the basic necessities that have shut down, or working in other ways to get resources to people, like at grocery stores. or as well as all the pre-existing conditions that can worsen a person's prognosis if they're getting COVID-19. And so as we're working with, I think the language of vulnerable populations is problematic, but thinking of in shorthand, thinking about all the people that are particularly at risk, either for getting this disease and then having worse outcomes, or for being further and further apart from the resources that they need to carry out basic functions. Trying to think about kind of both of those ends. And so as I'm trying to take some notes on what Dr. Ward was saying, to think about, how do we message the protective factors that we can all do. And so washing our hands is a big one. We're all trying to get the word out about that. But my mom is immunosuppressed. And so in the transplant days, we were very used to the, how to, take off the outside clothes immediately into the washer, and all of, shoes at the door, outside shoes at the door, inside shoes elsewhere, kind of all this information that others may not have. How do we get that out to people who are working in not necessarily in other essential services that may not have that information, to make sure that the spread is stemmed that way too. So there's a lot there. And I think, as Dr. Ward said earlier as well, that there's many different branches out of public health that until this moment may not have always been considered public health by the general population. So this is a moment where we're trying to bring everyone together to really ensure that all those aspects are seen as part of the same system.
Okay, and Erica, thank you so much. Again, I'm watching the clock here. We said 8 o'clock. We have Reginald Vickers. We want him to ask a question. And again, Dr. Harold Moore, who's a family physician, is with us as well. I'd love for him to share a word with us in a moment or two, but let me allow Reginald Vickers to ask a question. And then Dr. Moore, if you don't mind, if you share a few words with us. Reginald Vickers, the floor is yours.
Can you hear me?
Yes, we can hear you well.
Is there any kind of, I know immune is the issue. Is there any kind of anything from a naturopathic of strengthening the immune system, more vitamin C or a higher quality of vitamin C? What kind of vitamin C? Anything from that Savananda tree hugger vein? Because I'm really curious about that cod liver oil. Anything that we just have around the house that would help in the strengthening of the immune system?
All right, Reginald, thank you very much for that question. And I'm glad you were able to join us, because I know you had a busy schedule, but I'm glad you're here. Any panelists would want to address that question about the naturopathy, vitamin C, cod liver oil, silver black draw? I mean, just.
Only, Dr. Weaver, the only papers I've read, zinc supplements, which have been shown to decrease the risk of maybe contracting the regular cold or influenza cold, because it just inhibits some of the virus getting into the into your respiratory passages. And then I read, just kind of anecdotally, some reports saying that infusions of vitamin C, just massive doses of vitamin C, but those are all anecdotal. They are in the category of they probably don't hurt. Will they help? Nobody's really sure. Sometimes, I mean, like I said, zinc has been shown to kind of shorten the length of the common cold, which are mostly caused by viruses, including a different type of coronavirus. But those are the only two that I've seen some reports about. I don't know if any of my colleagues have seen anything.
Well, Dr. Moore had his hand up. Dr. Moore, please.
Can you hear me?
Yes.
Okay. There are also studies out, probably not written up in large quantities, but your carotenoid complexes, which also are strong boosters of the immune system. That would include your fruits and vegetables. So people who are eating large quantities of things that are in that fruit and vegetable complex may get some boosting of the immune system. We all know about the Linus Pauling theory, where the vitamin C megadoses also has been shown to boost the immune system. So there are some things that like that one can take to boost the immune system on a regular basis. Also, I've had someone send me information about doing lemon and hot water and tea and all these different things. I'm not certain how valid they are, but we know that in a lot of the, especially the teas, there's a theobromine that's in it, which is sort of a natural respiratory bronchodilator, and sometimes that may help. I did have a question though in regards to the pathophysiology of this virus and the fact that it does attack the respiratory system. And I was wondering, and I think Dr. Brown might be able to address it, were they using things like the mucomist, which is an old drug for clearing out mucus in the lungs? And I was wondering if that was being used at all.
Dr. Brown? Thank you, Dr. Moore. We can't hear you, Dr. Brown. Is it on me? Okay.
Cool, now I'm muted. All right. I got two parts to that. So to first answer your question, Dr. Moore, we are not advising the use of anything that can aerosolize droplets at all. Like I'm talking about like, we're not even doing nebulizer treatments in the emergency department. We're giving people MDIs with spacers and trying to improve their respiratory function. We're not doing anything other. When we do suctioning of people, for example, I had a patient come in with COVID who was also trached, and we had to really decide whether it was worth it to suction the trach area or if it would potentially spread the particles around in that room. Because the fact of the matter is we don't even have enough negative pressure rooms to do a lot of these things, right? So it is a risk-benefit discussion. So I don't recommend anything that is a spray or aerosol product unless there is a spacer or some type of chamber where it can then be passively taken into the system, because you essentially can aerosolize it at the speed of something like 400. I think they said something like, I don't know the distance, but it's the standard cough is like 60 of this particular metric. Aerosols shoot it out at about 400. So we wouldn't even want that to be in the environment. When I intubate people, I'm not giving, we don't put BiPAP on patients. We don't put high flow on patients because it potentially aerosolizes those things. We go straight from a non-rebreather to putting a tube in, right? So that's my first point. The second point was going to be as far as like naturopathic medicines, you know, Eastern medicine is built around a lot of this like overlap of using naturopathy as well as a little bit of allopathic medical treatments and even some osteopathic medicine, right? So my thought was, if in a place like China where naturopathic medicine is essentially a mainstay in the birthplace, if that was decimated by COVID-19, what is the proof that we know something is going to be, you know, our particular home remedies are going to stand test to this? Like, I just don't recommend it to people. I say do whatever makes you feel comfortable, because this is only symptomatic treatment, but don't expect it to be a shield for you.
Okay, Dr. Brown, thank you for that. Obviously, looking at the clock, it's 8:03, and we have so many questions that are coming in. So if everyone could give us a few more minutes, again, I want to be prompt and I want to be respectful, but then there's still some burning questions out here. So, I mean, if we can go until 8:15, I think that will give us enough time to deal with these questions, because again, that's generally how it goes. The conversation gets going and we have to shut it down, but we do have some flexibility. So if everybody could just stay online with us, we would appreciate that. I have Willa Hightower, and again, thank you to the panelists and to everyone for hanging in there with us. We're a few minutes over, but we're going to go until 8:15, and then we'll go ahead and call it a night. So again, Willa Hightower, Ms. Hightower is online with us, and she has a question. Let me just unmute her. So Willa, please, can you ask the question? And Willa's in Philadelphia, everyone.
Yes. So good evening. As he mentioned, I'm in the Philadelphia area, and on behalf of my children who are ready to go back to school, what's the likelihood of that happening? When do we think this is going to kind of peak out and play out such that we can go back to what I'll call quote unquote normal?
And that's a real question, a real heartfelt question. Dr. Salisbury, Dr. Nelson.
No, I have no idea.
Okay, well, that's straightforward from Dr. Nelson. Dr. Salisbury.
Yeah, if you look at what they're looking at, trying to extrapolate this curve to try to flatten it, you know, at this point, you got to think about different areas of the country. Obviously, you're dealing with the Northeast, where we're epicenter right now is New York. You look at the West Coast, looking at California, LA. You look at Washington State, Seattle, Spokane. And again, now we have New Orleans getting hit hard. You got Chicago, you got Michigan now. I would think the likelihood of students returning to what we know as physical school for this year probably won't happen in certain areas of the country. Now, I'm not saying this is going to happen for the entire country, but when you think about where we are right now with this pandemic, the likelihood, and just a simple, do the math, do the numbers, you know, you let kids get back to school, hugging and kissing one another, not washing their hands, you know, on proper hygiene. They're taking this stuff back to their homes. You don't know if they live with their grandparents. You don't know if there's any comorbidities in the house, you know, things along those lines. So just to err on the side of caution, I agree with Dr. Nelson. I don't think this is going to happen.
And on that note, again, thank you for that, Dr. Salisbury. Let's get ready to sort of wrap things up because I know we can keep this conversation going. And as I mentioned, we will have a follow-up. We just need to, you know, decide when we're going to have the follow-up because, again, this is, as Dr. Salisbury just mentioned, this is going to be with us for a while. Let's pray to God that it's not here to stay. You know, I think we will get in front of it at some point. But at this point, you know, the curve is not flattening as much as we'd like to believe it. So on that note, let me just go to the panelists one by one to have any closing remarks. Again, we thank everyone for being here with us. So I'm going to start with, you know, as we started in the beginning, Dr. Jasmine Ward, please, can you give us some closing remarks and we'll just go around from the panelists.
Okay, sure. So I think from my perspective in all of this, I'm very grateful to hear from the medical doctors, especially frontline working with COVID patients at this time. One of the things that I want to make sure to note is that they have our support from those individuals like myself who are in public health. I'm home with 4 kids, so trust me, I understand that question, that last question, and trying to make sure that we are staying focused and staying the course and helping one another, you know, get through this. But remember, my word to everyone is grace. So when we think about individuals, we have to realize that behavior changes and these recommendations are going to be difficult. Have grace on give yourself grace and others, and recognizing that we need to make sure that, I mean, this is a heavy lift for us. So just stay in there with us and try to follow recommendations and model good behaviors, y'all. Model it. That's pretty much what I've been working with at this time. So I do appreciate the conversation today.
Well, thank you, Jasmine. And Erica San Hernandez, one of my star students there at Simmons University. Please, any closing remarks? Oh, I'm sorry. Yeah, I got it. There you are.
Thank you. Yeah, I think in addition, I would just add that you know, it's acknowledging, I think it's important that it's really scary right now and very anxiety producing, that, you know, there are a lot of people who are working overtime and overdrive trying to figure this out on many different fronts. And I would also add that I think just to continue that it's frustrating to see the federal issues and how this is laying bare structural issues and inequities in health in a lot of different ways. And so as we're thinking about to the future, hoping that, you know, as we're all working to try and in the now see how we can improve lives for people that are impacted, and everyone in some way is impacted. How do we continue to put pressure on future policy change, future structural change, to try and move towards, within the parameters of the system that we have, which is obviously problematic, how do we make sure that people have their basic rights and needs met, like paid sick leave and all sorts of other aspects that would truly make a difference in the way that such a pandemic in the future plays out. And I guess the silver lining that I try to see, which is tough, to hope that this bolsters the case and brings people, more people who had never considered health inequities before and never considered the possibilities of these structural barriers to health and truly at this point life, that maybe they will get on board more to really create a tipping point that we can make these things reality.
Okay. Thank you, Erica, and we look forward to you going into a doctoral program soon. All right, let's get you through the MPH first. Dr. Salisbury, please.
I would just say to the group, you know, this is let's sort of buckle down for the long haul. I think, you know, we're looking at 30 days as sort of the benchmark, but I would be remiss to say that this could be a rebound effect in the fall. So as much as I'm optimistic, I'm sort of a realist at times as well, that, you know, until we get a vaccine, which is, I will tell you, is not around the corner. That's not how the FDA works. You know, vaccinations, first of all, we got to get the exact strain of COVID-19. You know, even before we begin to talk about vaccination. So I would leave the group tonight to say, let's listen to the experts. You know, Dr. Anthony Fauci, my hat goes off to him because I don't know how he does it. Because, you know, the information that he's trying to bring to this country and this nation is being questioned in real time. And as I said earlier, you know, once the horse is out of the barn, it's hard to catch that horse. And we had plenty of time to deal with this. And, you know, some of the pleas fell on deaf ears. So, you know, I just want people to be remiss that, hey, let's just buckle down for the, you know, long haul. This is not something that's going to go magically away in the next 90 days. This thing is here. It's going to be the new normal.
Strong words. Dr. Nelson.
Yes. I'd just like to piggyback on something that Dr. Ward said when educating the lay public, the public. One, this is so insidious because the incubation for COVID-19 is 2 to 14 days. So you can walk around infecting people before you even have any symptoms. And a lot of people will have mild symptoms. Like Dr. Salisbury said, there's no vaccine and there's no treatment. So just when you're and to tell patients or tell the public that viruses can live on surfaces, that's why it's so important to clean surfaces. And it's been demonstrated that just Clorox wipes will kill the virus. If you look on the bottle of your Clorox, it says coronavirus, it will kill them. So just when educating people, tell them this is why we do it. This is why we are self-quarantined for 14 days, because you can be infectious before you have any symptoms. Two, I am glad that this discussion did not get political because I have a lot of opinions about that. I think Dr. Salisbury was kind of alluding to it. There were a lot of mistakes made, a lot of mistakes that are fairly evident to even a non-medical person, but anyway. And number three, I was like, is this the end of the world? But there was a pandemic in 1918 that killed over 500,000 people. So it can't be worse. So with God's grace, we will get through this. We just have to, we'll get through this.
Thank you, Dr. Nelson. I'm going to call on Dr. Italo Brown, but Dr. Moore, Harold Moore, if you have a word or two that you'd like to share after Dr. Brown finishes, then feel free to be ready to say a few words. Dr. Brown, any closing comments? Oh, I got to unmute. Yeah, I'm sorry. There you are.
I'll be brief. I think that people just need to take a second and really understand that this coronavirus is non-discriminatory. it will have its effect on a person who would potentially like if it is in the presence of you and you will have you can have this, and it doesn't matter whether you are black or white, whether you are old or young, like it does not discriminate. But with that said, like I think that there is hope in knowing that everyone's effects are not the same, and that many people are on their recovery portion. And you got a ton of minds that are just like churning like around the clock to try to figure out ways to mitigate things. And that's the most encouraging part to me is like, you know, this has gone to a point where it is not just like a state or a local or a countrywide thing. Like multiple agencies across the globe are working together to try to solve a problem. And when you have that happening, it's like the greatest brain power ever. So I'm encouraged by that and seeing how we are, you know, literally being interconnected by this issue. So my comment essentially is like, you know, follow the public health recommendations for this. I mean, it took a long time for people to start wearing seatbelts. Yeah. It took a long time for people to start reducing their smoking. It took a long time for people to wear condoms. It took a long time for people to do a lot of the public health measures. This is going to be one of those where you have to actually take it seriously. So be encouraged about the work that's done on front line and in the lab.
Thank you for that, Dr. Brown. And you'll notice that in the chat that I did put the CDC's guidelines, recommendations. Make sure that you click on that link and follow those recommendations. Dr. Harold Moore, would you like to say a word or two before we adjourn for the evening?
I sure would. I agree with everyone on the panel. I think the key here is patience. And unfortunately, you know, we're so used to getting out and doing things and living our life like we normally have in the past, and a calling that things are changing. So I think we have to maintain patience, respect the professionals in the healthcare field who are making the decisions, because we have great people out there who know exactly what to do to find a treatment for this virus. We just got to be patient and wash our hands and cover our face, don't cough on people, and you know, just follow those rules, those simple rules, and we'll overcome this. We will.
Right. Well, with that, again, thank you, Dr. Moore, for those closing comments. I want to take a moment again and thank everyone for being here. My distinguished panelists, guests who took time out of their busy schedules, and of course, everyone who took time out of their schedules this evening to spend this hour and 17 minutes or so dealing with coronavirus and really looking at it from a communities of color perspective. But I think, you know, Dr. Brown said it best, as we know, that this virus is non-discriminatory, and we have to be cognizant of our surroundings at all times. In addition to making sure that, of course, you know, we wash our hands, we cough into our elbows and things of that nature, into the pit of our arms. All of what we've been told, we need to make sure that we follow. So again, I want to thank everyone for this first series. I know everyone is saying, you know, we need to do it again, and we can do it again, and we will do it again. We just need to figure it out, and we need to get the word out. Yes, for the first time out, I think this went extremely well. So again, I want to thank everyone. I did put my email address in the chat, that if you want to be on our email list for the next time that we are here, that you want to make sure that you're being, you know, that you're going to be notified, and we want you to be here to continue this conversation. So again, I just want to thank everyone. I know we've gone a little bit over, but I believe it was worth the time. And without anything else, again, prayers to all of you, prayers for our country, and even prayers for our leadership. Probably more prayers for our leadership. And, you know, that again, we will get through this together. The question is there a place to donate supplies? Does anybody know if there's a place to donate supplies? That was a question posed by Aaron. I'm not sure. Italo, quickly, Italo, please, Dr. Brown.
Well, the question I had is just what kind of supplies. My thing is, if you have extra PPE or something like that, like masks, the first place you should look at, honestly, Mask Match, MASK Match. Mask Match is an organization that's set up to try to allocate supplies to hospitals in need. So I would start there if you have access to masks. Other PPE, I think that would have to go on a case-by-case basis, but start with that.
All right, thank you so much. Okay. Well, again, we're not going to keep you. It's 8:20. We'll see everyone the next time we come together. Let's get the word out, get more people in, and continue this conversation. Everyone be blessed. Thank you for a wonderful evening, for a wonderful panel, and we'll see you the next time. Bye-bye. Okay.
Bye-bye.
Bye-bye.